Would like to invite Dr. KG Suresh, who is the consultant diabetologist at Manipal Hospital, and Dr. M.A. Shekhar, who is the Vice Chancellor, Adi Chunchungiri Institute of Medical Sciences, Mandya, the Professor of Medicine.
Good evening, everyone. Dr. Shekhar will introduce Dr. Basavanagowdappa, sir.
Very tough job. Good evening, everyone. I keep telling Basavanagowda, we are of the same age. Can you believe? I keep telling him that his birthday is on February 29th. Every 4 years he becomes 1 year. We tend to become every year an older person. And I don't need to give any more explanations for this extraordinary guy. But let me remind you, Virginia Slims, you remember? I'm sure senior people will remember. Very thin cigarettes which were introduced way back in America exactly for ladies, not for gents. The tagline for this cigarette was, "We have come a long way, baby." This guy has come a long way, baby. In the last 40 years, he has reached such extraordinary heights. I'm proud to say you are my friend, my guide, and a very good brother. And I'm sure he is going to tell you about, it was very simple 40 years ago. Give 2 tablets, look at their blood glucose and be done with it. Today, we have to look at kidneys, we have to look at heart, we have to look at every damn thing and also look at the pocket. He's going to confirm what he is going to talk. Thank you.
Thank you, Shekhar. Thank you. Good evening to everybody. I am happy that I am having at least a good number of audience here, though the IPL match, the inaugural match is going to take place today. I was telling Srinivas Murthy, he never asked me what topic to be spoken about, and a few days back he just flashed this program list. And he was trying to check me whether I can deliver some points on this topic. Let me just try and see whether I can meet his expectation. This is not a topic where I'm having any influence by any company or not a molecule promotion talk. In 15 minutes, I'll just try to see few points of my viewpoints about what are we doing to an individual who walks into a clinic with multiple comorbidities within himself. Is there a future models for holistic care in such an individual with a multi-morbidity? That is my the talk, and these are my credentials. And greetings from JSS Medical College and Hospital and JSS Academy for Education and Research, where I have taken the baton of Vice Chancellor for the last 4 months. As I mentioned, no conflict of interest, purely an invited talk designed by Dr. Srinivas Murthy. Thankful to you, Murthy, for this wonderful opportunity. We all know, we very commonly keep seeing how common is comorbidities in a given scenario. 1 in 4 adults will have more, 2 or more comorbidities when you screen them across. Among those adults who are admitted for some reason, 75% of them, 3 in 4, will have more than 5 comorbidities. Problem is not exclusively for elderly people. As evidenced by survey and data, 30% of the younger adults, less than 65, also will have 4 or more conditions coexisting together. The proportion of adults with multiple health conditions, that is multi-morbidities, are rising rapidly. Young India is now aging, and the world is aging. With that in mind, let me ponder around what happens when there are comorbidities: the higher rate of complications, reduced quality of life, increased mortality, and increased healthcare costs. Now, these are the depicted numbers. In a diabetic, if you just take diabetes as a king comorbid condition, what all will be associated with him? The most common condition that get married with the diabetes is hypertension. All those conditions which are listed there can be existing in multiple combinations and permutation in a given individual. Having said that, this picture will help you to say, you pick up some of them, 3 are existing together in a given patient, 4 may be existing, 5 may be existing together, but the king comorbid condition is diabetes in the center. They are prone to develop so many other conditions, most commonly the depression, cardiovascular comorbidity, respiratory disorders, infections, sarcopenia, obesity in the other extreme, thyroid disorders, MASLD, king of comorbidities, of course, diabetes, rheumatological disorders, and so on. Imagine an individual with so many things coming in. I'll give an example, a very simple case as hypothetical. Mr. Ramalingam, a 65-year-old retired school principal, famous for his ability for teaching students, arrives into a multi-speciality hospital. He is escorted by his ever-dedicated wife, Mrs. Ramalingam, who has now become an expert in navigating through OPD queues. He has diabetes, hypertension, chronic kidney disease, osteoporosis, neuropathy, COPD, and a touch of forgetfulness, or a selective memory, as according to his wife. Let us see what happens to him. He walks in because one of his neighboring friends said, you have a swollen limb, better go and first consult a nephrologist. He goes to nephrologist. Nephrologist says, Mr. Ramalingam, your kidney functions are stable for last 6 months, creatinine is 2.5, but your creatinine is creeping up little bit recently. That is because your sugars are not getting controlled. Better you control your mind, your diet. He says, of course, doctor, I am taking low sodium, low potassium, that we have told. And your sugar, because your sugars are fluctuating, please go and get it fixed with your diabetologist. They are all staying in the same floor or different floors of the same hospital. Now he walks into a diabetologist. The diabetologist says, Ramalingam, your HbA1c is 8.2. It is not controlled. And are you controlling your diet properly? Ramalingam says, doctor, my wife ensures that I eat a monk's food. No sweets, no rice, no happiness. Still, my sugars are high. What should I do, doctor? Please tell me. Diabetes says, then we need to adjust your medications and readjust your diet. Even monk's diet getting refined. But your ECG is showing some changes. Better I advise you, please go and consult your cardiologist. And he comes to cardiologist. Your ECG shows changes. Your echo suggests LV dysfunction. We need to plan for a coronary angiogram. Since your creatinine is high and also your SpVt is little low, I want you to get certified by nephrologist and pulmonologist to say your cardiologist can go ahead with the angiogram. And this Ramalingam is perplexed. What should I do? He salutes all of them. And when I got this case scenario, I just gave a question to AI, Meta-AI. I asked the Meta-AI to just give me generate an image, imagining that a single shirt is being stitched by 4 tailors together. One is sleeve specialist, another is collar specialist, another is pocket specialist, one more is body shape specialist. Okay, imagine what would happen if these 4 tailors are made to stitch a shirt. Okay? This is what is happening today. We are losing family physicians who can comprehensively give guidance to you. Only take help from one specialist if required. We are losing general physicians, generalists, because everybody is getting into piecemeal care by a focus specialist. Everybody is doing their good job. But ultimately, 4 diseases handled by 4 different specialists. There, at least when the AI, I asked it to generate image yesterday, it gave 4 tailors sitting together to stitch a shirt. But are we having 4 specialists sitting together to do a combined study on a case to design this is what a therapy should be in all the 4 angle points? It's not happening. It is a hard reality. It is a hard reality because we are creating more specialists, a focused care is given, in his viewpoint, what he has given is right. Ultimately, the individual ends up with a lot of confusion about the diet, about the medication, drug-drug interaction, disease-disease interaction. Ultimately, he gets into polypharmacy, dies little earlier than if he had not met these specialists. This is I'm sorry to say that this is hard truth. Every one of you agree with me. Then, what are the solutions? Have we lost a basic care provider who can sit and spend time with you, look at all those aspects, only take help from? If those 4 specialists had sat together and designed a therapy, this fellow would have got better guidance, better survival rate, but he didn't get that because they don't even bother to call across what prescription I have given, you follow it, your kidney will be better. I'll postpone your requirement of dialysis. That is what nephrologist said. Cardiologist said, I will give appropriate medication, but I'm waiting for certificate from nephrologist to go ahead with your angio because otherwise your kidneys are going to get worsened. This is what is happening in the hard reality because we are focused into a specialty-driven care in a piecemeal manner than combined, comprehensive, holistic care. That's why Srinivas Murthy designed this topic. Is there a future model? What is the solution for such happening? Now, solution is integrated diabetes care clinic, interprofessional coordination, which is not happening, should happen. In the same hospital, the next specialist will come and see the reference. He will not even bother to know what the other specialist has given a prescription. That is happening. It is needed to have interprofessional coordination, delivering patient-centered care according to their multi-dimensional needs, improving patient experience by shared decision-making, integrating specialist care into primary and community care setting for a management of comorbidities. Now let us look at the medical education. Medical education. Let us say in a UG clinics or a postgraduate clinical seminar, a case is given, he is directed to take that case of mitral stenosis with thromboembolism. We never say the discussion takes place, a lot of discussion takes place, how to elicit a sign and how to come to a conclusion. You end up with a diagnosis, little time is spent on therapeutics. This is a hard reality in medical education. I yet to remember or see any teacher who sits and takes a case of 5 comorbidities, discusses how do I address each one of them, how do I manage my therapy, how do I prevent polypharmacy, how do I make those drugs work for taking care of all the 5 pharmacy. Do you remember as a postgraduate in the medicine or an UG in your clinic, a case of comorbid condition is taken and discussed comprehensively, how do I design you to be a future doctor of a comprehensive care provider? It's not happening. So are we doing wrong thing in designing our curriculum? Is a question that has to be put in because you cannot have a luxury for somebody walking in calling 5 specialists for me to sit together, discuss my case, and all of you come with a common guideline prescribed. It is not going to happen, and our patient do not have that luxury of affording a combined consultation, walking into him and giving a... Now, this is the era of AI. Is there a provision for a given consultant, diabetologist, or anybody to take help of AI, developing an algorithm? You feed all the data, all the reports, all the comorbidities. Can it help you to give you an idea? How do I design my therapeutic approach? Starting from lifestyle to nutrition therapy, because it changes. In UG clinics, I often come and shout at the students when they say dietary history, mixed diet. They don't say how much of calorie, how much of fiber, is it balanced? Is he following the diet advised by his dietitian for his diabetes care? Nobody looks at writes there. He is compliant with diet. It is not mentioned. I tell them, look at these things. What you want to do therapeutically is not just prescribing a drug, it is prescribing a nutrition which is forgotten, which is failing because we are failing to guide them properly to which is the important component of each disease management. So, as I mentioned, there is no combined study about a case between the specialists. Okay? Now, can we pray for AI to make that happen? It is possible. There is AI-driven predictive analytics are available now, AI-driven support with clinical decision making, mobile apps for patient engagement, and telemedicine for remote monitoring. There is one app developed by BMJ, best practice, for a comorbidity manager. Okay? It comes to a help of an individual. I don't want to keep on happening. So you just feed the data. It tries to give you a possible approach. This is the modern model for a holistic care, possible holistic care. I'm not telling that it is foolproof, it is evolving. If that kind of apps are available, an individual can be prevented from going from door to door of an individual, but he can take a precision guidance from this app to say what should be prescribed and what can be the way to take care of comorbidities existing in a given individual. It helps in advancing holistic healthcare approaches, improve access to care, promote generalists than specialists who can comprehensively give a care to you. Only he takes help from his colleague specialist in a given situation if required. A clinical decision support system can be a way. Though all thing is about integration of the care. Socioeconomic influence has to be kept in mind. I cannot prescribe a medication, a combination or a referral if he cannot afford. So you have to look at that. Health system approach has to be different to improve the access to the care, promote generalists. I keep telling generalists, you have to have more sensible general physician with us than more specialized people in each specialty. Provide a decision support and also build doctor-patient relationship in a better way than what's happening now, which is deteriorated. Promote shared decision making, which is very, very important because patient-centric approach with a holistic care, the combined effort is what is required, which is failing, and supporting patient with self-management is very, very important. So what are the solutions? It can be three-pronged attack. Revise, revamp, and try to redesign our curriculum for designing a generalist or a family physician, which is fading away, the image of family physician. I just gave another request to AI. Give me an image of a very good Indian family physician. Okay. It gave a smart lady with a stethoscope hanging together and then looking politely at the individual. So we need to think whether we should redesign our curriculum in such a way that even practical training, a case discussion, maybe we take help of AI, but nothing to replace an individual. At least there should be sessions where comorbidities are discussed and therapeutic approach for that comorbidity has to be taken, which is not happening across the institutions. A structured process for the care to be transformed so that it becomes more patient-centric. A system of healthcare professional education needs to be changed and improve undergraduate and postgraduate education in this area of doctors and other healthcare professionals. This is what I have told you. BMJ Comorbidity Manager is there. It can help you. But all these can be addressed only if you give correct data to the system. And we need to take care of all those things. There are so many algorithms available, if this is there, this is there, this is there along in a same patient, how do you approach? There are so many guidelines, and new trends are there, but new opponents are there for the trends. So many respiratory disorders, so many serious disorders, depression very commonly associated. To conclude, friends, I have not given you a great talk on any molecule, but I have just made you to understand where are we today in handling a given individual with comorbidity. Are we making them to wander from one specialist to another specialist, ultimately culminating into drive him with a polypharmacy with drug interaction and die little earlier than otherwise? So there is a growing number of patients with multiple comorbidities or multimorbidity. Managing such patient is challenging, but better management will represent a strategic step change in the implementation of evidence-based medicine, greater need for redesigning the curriculum, teaching, learning, resources and methods from management of a single disease to comorbidities. The comorbidities manager can be helpful to some extent, but there is a need in a given situation. The concerned specialists should sit together, discuss, design, and one individual has to be following up for monitoring and appraisal. With that, I thank you all for patient listening, and I thank Srinivas Murthy for providing this opportunity, and my good friend who keeps always praising me for my younger appearance, which is modified appearance, my Shekhar, and Suresh, of course. Thank you.
Thank you, sir. Anything you want to?
Okay. Any questions?
Is the most important contemporary thing in many diseases, including diabetes. In fact, I just heard a talk on the comorbidity disease, comorbidity and multimorbidity. When more than 2 or 3, they call it multimorbidity.
Yes, sir.
From one gentleman who is the primary care. That's what I think Sir was driving all the time, that we have to concentrate on the family physician. The lady, I don't know where from he got that lady, but you know, he was alluding to a good primary care physician who can take care of the multimorbidity. To make a long story short, I must mention that when I heard the talk by Kamlesh Kunti is the professor of primary care, OB, Order of British Empire, my collaborator in the Leeds University. He gave a graph. As the disease of diabetes increases, the multimorbidity increases. And at the end of 40 years, 45 years diabetes, you have multimorbidity numbering 8 to 18. Therefore, it is inevitable. And you know, he has given very quick recapitulation of what exactly happens. And as you rightly pointed out, it is the depression, the respiratory, the locomotor. You, sir, you can modify. I have also modified. So, but you cannot multiply your knees. You cannot multiply your knees. So, you
Absolutely.
know, locomotor system, you know, these things definitely catch up. So,
You are the same for last 20 years, sir.
we are very common friends, Vice Chancellor sir. But Dr. Vishwas, my senior, came to his institute. They got NAC double plus, give a round of applause.
Thank
you know, we work together. And Adi Chunchungiri, BC also is here. So I must tell you, sir, it is very important. He gave a good solution, sir, that I wanted to point out. He said, if you do regular physical activity, I'll repeat again, regular physical activity, you can keep away many of the multimorbidity for a longer time.
Absolutely.
That is the study, and they have taken this from the British Biobank data. I think, sir, being a Vice Chancellor and giving such a erudite talk is rare. Thank you
sir.
very, very much.
Thank you very
for the
much,
great
sir.
talk.
Because there are 2 vice chancellors here, educationists.
Yes, sir.
I have one comment. See, what is happening in our system, particularly corporate setup, what is happening, the public awareness has become extremely high. The so-called idiotic syndrome is coming to the picture. Information-derived obstruction for the treatment. See, just extrapolate this to the older generation, where when we were boys, we had LMP doctor. The LMP doctor is specialized in all. And he used to be the treating doctor, he used to be the philosopher, he is the guide for everything. Over the years, over the decade, this mushrooming of multi-specialty hospitals, multi resources and availability of any number of plenty of super specialties. What happens because of the increased awareness of the public, if he gets a headache, he will put into the chart shop and he will go to the neurosurgeon. If he gets diarrhea, he won't go to the physician. He will go to a gastroenterologist. If he gets convulsion, that is the only correct place where he will land up in the. What is happening because of this increased awareness? We have to, for both of you, I am telling you, we have to bring in our country the so-called referral system. See, for example, in UK and USA, you cannot go to a straight away specialist. You have to go to a family physician, then you have to get a reference to the physician, internist they are called, then you have to go to super specialist. If you can bring in that referral system in our country, this problem of patient landing of various super specialists landing it more problem, this can be totally prevented.
Sir, nobody is interested to stay back as a MBBS qualified family practitioner. That is one. Everybody want to become a specialist. Number two, referral will not happen because one fellow has to refer to 10 people. If that is the kind of expansion. Though our union government now says, keeps on telling, we will add 75,000 extra doctors every year.
His point was,
5 years down the line.
Basavanagowda, his point was,
Yes.
a fellow with a headache cannot go to a neurologist without a referral.
Unless he passes
Right,
through
sir?
the. Yes, yes. That's correct.
Thank you, Basavanagowda, good friend of mine. He has stressed two important things. One is general physician or family practice. Second is the curriculum. I think we are doing this for years. It has not changed. Now, where are the problems? Who is going to address this is difficult. Now, first problem you said general physician. If you go to a single center specialty institute, for example, cardiology or neurology, you don't have a physician there. Now, when patient enters or leaves the institute, ideally is they have to go through one of the physician they can keep. They keep so many cardiologists, neurologists, or gastro. I think ideally is such institutes should have at least one physician, where when they are leaving the institute, the drugs, whatever they were taking, will be missed when they are going out. That is the usual trend, what we see. I think that is the solution for the single center institutes, where ideally they should have one physician, where patient either entering or leaving, they should go through that. Second is, you said even the well-educated people find difficult when they are seeing so many specialists. At one point, I was called by one of the...
Could we curtail it?
Yeah.
Ask a question.
Yeah. Famous people also find difficult. The last is education, you were telling, the curriculum. I think we tried to do that in API. We did recommend to the Rajiv Gandhi University. Somehow it was not implemented. I think Das also was there in one of the workshops long back we did in 2008. Now there is a lot of resistance to change the curriculum either by university or the MCI. So as a VC, two of the VCs who are here, try and see whether you can change the curriculum in your given universities. And the method of clinical examination, you said, now that should be changed.
Thanks, boss. Thank you. Thank you for
Thank
this.
you.
I request, sir, we will have the question later. I think we are running out. Let me conclude in 2 minutes. The first one is, there are two vice chancellors. I remember my chancellor, Paramapujya Swamiji, asked me, Dr. Shekhar, tell me why it is spelled V-I-C-E, not W-I-S-E. We are still vice chancellors, not vice chancellors. So we have some time to go ahead. And it is time, after Dr. Basavanagowda's speech, every one of us introspect where we are, whether you are a specialist or whatever, because the third cause for death in America is prescription. And the last thing, a student carrying 8-10 kgs of a bag looks at the teacher and say, why should I study maths, social science, mathematics, all those funny things, and there are so many teachers and only one student. Same story is the patients. Why a patient should be referred to so many so-called teachers to help them out. We have to really introspect and decide where we will lead to. Hopefully, from Vice Chancellor's seat, we will change the curriculum.
Thank you.
Thank you. Thanks, Dr. Basavanagowda.
Right.
Thank you to the speaker and the chairperson.